going to hear today about fibroids. Ebby, thank you for being here.
Thank you for the invitation. Thank you for referring to me as a young woman. That doesn't happen very often. And thank you for all of you that are up this morning if you watch the game. When I heard the news this morning, I said, oh my goodness, this is going to be a long morning. But I think you've had the cases at M&M's to keep you awake. And this is one of my favorite talks to give because it really brings together the two halves of my academic existence. I am a reproductive endocrinologist, so I do infertility work in IVF, but most of my research centers around uterine fibroids. So this really looks at both together. And I think that one of the big summaries, not only of my work, but of many of our works, is that we absolutely need better evidence for the women we care for, and fibroids is one of those big fields. So I have some disclosures. These are all of the disclosures I've had over the preceding 3 years, and all of the grants relate to fibroids with the exceptions of one company where I work with them on adenomyosis and a startup where I work on a fertility monitor. All of the corporate work I do is related to fibroids, and I do receive some royalties from some of the things that I've written. But I have a couple of learning objectives today. I'm going to start by discussing why it's so difficult to get evidence about fibroid care. Then I'm going to review what little evidence-based guidelines we have on fibroid treatments for infertility, to look at some of those limitations, and then finally to look at the other side of the coin, because we worry about the fibroids, but we also have to worry about the treatments that we do for fibroids. And so I'm going to try to gauge where we're starting. So you have a 28-year-old woman, she's been trying for pregnancy for a year, you've done the workup and everything is normal, and you find a uterine fibroid. So what are you going to tell her to do? Are you going to tell her to proceed to fertility treatment, or are you going to concentrate on removing the fibroid? And I've got some examples for you. So this is from something we wrote a year ago. So how many people would take this woman with this single subserosal fibroid and recommend that she have something done about her fibroid before she pursues fibroid treatment? Not even one adamant surgeon that's going to take it out? Okay, what about patient B? Yeah. Okay, now there's two questions. Are you going to take it out because of this fibroid? Or are you going to take it out because of this fibroid? Who's going to vote for the smaller, superior fibroid? Okay, who's going to vote for it for the lower fibroid?
And who's not voting because they have no idea?
So what about this one? Here you can see the cavity kind of here, and this big, who's going to tell? Okay. What about this one? Okay, so not clear consensus except potentially about this case where it sounds like everybody is going to move toward the operating room. So I think that there are some things that make acquiring evidence difficult. And I think of this in terms of either sins of omission or commission. So we spend a lot of time worrying, well, we know fibroids are related to infertility, they're related to miscarriage, they cause pregnancy complications, but we often then don't think about the other side. What's the evidence that removing them will return this woman to totally no risk, or what new risk can come? So I think we have to constantly be balancing those two sides of the equation. And this one is a really strange one when you go speak outside the US, because they have no idea that this exists, that in the US, the bias is to do the fibroids first because insurance covers the fibroids, and at least most of us are working in states where people have to pay out of pocket for fertility care, and this is a totally foreign concept to most of the rest of the world. So I think that this is a very real bias in our practice that doesn't exist in other settings. So the fact that we do this relates to the system we're in and not necessarily to evidence. And I think, again, there are many confounding factors. You know, women tend to develop increasing number and increasing size of fibroids as they age. So if you've got an impact of a fibroid, is it really the fibroid or is it the age? Again, it may relate to access to care in some women. If you know, the fibroid has grown and grown and grown and it's now large, is it really just the fibroid, or is it the fact that she didn't get routine gynecologic care for 5 or 6 years when their insurance lapsed? And I think one of the most difficult issues is the racial disparities of fibroids, and I have a whole separate talk on that about differences in the biology, differences in women's perception of treatment options and their priorities. So I think the fact that fibroids are more severe, more prevalent, and probably have different biologic behavior in Black women is a key issue that we face. I think that this is some of the key evidence, and there aren't many fibroid papers that are published in PNAS, so if you haven't read this one, it's absolutely worth reading. This is Donna Baird's group, and that it's amazing it took to 2008 to document fibroid growth. They did MRIs 6 months apart and found that fibroids can grow up to 138%, or they can shrink substantially, so that there is a regression pathway, and if we could figure out how to harness that, we might have fibroid prevention. But I think this is the interesting issue with racial disparities. If you look at white women, so if you're looking at growth, women under 35 are a referent, and as women get older, the fibroid growth slows down. So they're -7 between 35 and 40, and -19 at age greater than 45. So I don't know whether all of you learned the same thing I learned, is that if you can just temporize to menopause, just get them out there, go a couple of years, we can get there. And if the fibroids are slowing down in their growth as they go through their reproductive lifespan, that's good advice. But for Black women, they see a little bit of a slowing of growth, 35 to 44, but not really any as they approach menopause. And again, there's increasing biologic data. Erica Marsh has some data about steroids and Black women, so there's something different about the biology. So trying to temporize to menopause may not be as an effective a strategy for Black women as it is for white women. And this is some of the work that we did that did a nationwide survey that was powered to look at racial differences. And Black women tend to have different concerns. So this is probably too small to read in the back. But women were more concerned that their fibroids would grow. They were more concerned about the impact on pregnancy. They were worried about fertility and sexuality and undergoing treatment options. And they were particularly have increased concerns about treatment options that preserve the ability to get pregnant in the future. So I think that's one of the key issues we face when we're thinking about fibroids and fertility in Black women, is that they do have different concerns, and that, again, sometimes we see women that we say, oh, they were non-compliant, they came in and we recommended a myomectomy and then they went away. Maybe we weren't able to address their concerns. And I think this is a key area where we need to do better. I think fibroid randomized clinical trials are especially hard to perform in US populations. If you look at studies comparing surgery to uterine artery embolization, there are multiple randomized clinical trials, but they were all performed in Europe. They were done in the Netherlands and in Prague and in the UK. But to get US populations to consent to randomized clinical trials when they can walk down the street in many big cities and go to a different program that offers them the treatment without a trial is really tough. I've been involved in 2 randomized clinical trials, and the first one we did focused ultrasound surgery versus observation. They were women who had unexplained infertility, and so we were trying to see whether treating the fibroid was beneficial in a relatively non-invasive fashion, so that maybe they did better. Maybe the reason that you had problems after some fibroid surgeries was because of side effects of the surgery. Well, we randomized 2 subjects, and then the company closed the trial because no one else could recruit to the protocol. So it became a case report rather than a long report on an RCT. And we've just completed our big NIH-funded trial. We just published the baseline data on this, but it took us much longer, and we still didn't get all of the subjects that we wanted to. So I think that will give us some information, but it's really hard to do RCTs, particularly in our field. So I want to review a little bit of the evidence-based guidelines on fibroid treatment for infertility. So this was a Cochrane review published in 2012. And so if you're looking at level A evidence for treatment of fibroids for fertility, there's 1 randomized clinical trial. And it not only compared myomectomy, it pooled open plus hysteroscopic, which I think most of us would say is totally 2 different animals. It's putting the lions and the tigers in the same cage, and probably more. Whereas you didn't have a benefit if you treated an intramural or subserosal. So getting back to that picture B, where you had the teeny tiny submucosal fibroid and the enormous fibroid that was intramural and anterior. This would suggest you could treat the little one. Now, the fact that you probably couldn't get a hysteroscope around that big one may be another issue, and luckily this lady presented with unilateral leg swelling, so they worked her up for DVT. It was filling her pelvis, so for her it was not an issue, and she ultimately did conceive and deliver. But again, does that make any sense? That, you know, you've got this teeny fibroid distorting the cavity, you've got this big one expanding it, pressing on the cervix. Does that make sense? I don't know. There also didn't find any significant differences in terms of miscarriage rate. So this is the best quality evidence we have. So if you go back to that original study, there are actually some good strengths of their study design. Everybody went through a complete infertility workup, and again, both clinically and research-wise, I find that's the biggest thing that, you know, I can't tell you how many times I've seen a woman referred to me for fibroid care for fertility, and I go, well, what's the semen analysis? Well, we haven't gotten to that yet. Or the time I was called into an OR because they suddenly described big hydrocele peaks that, again, they'd worked her up, but they hadn't looked at the other elements of her fertility care. The other strength of this study is that women were under the age of 35 and that they really had infertility. They'd had a mean duration of infertility between 1.5 years and almost 2 years. But there's some weaknesses in their study design as well. So they had a single fibroid less than or equal to 4 centimeters. And I don't know about you guys, but I haven't seen one of those in many, many years. By the time I see people, they are either, the one I operated on Monday had a 7.5-pound fibroid. So, you know, that's the kind of population I see. So we'll never have evidence for that. That they also, the way they handled this is that the observational group really had 3 additional months to conceive because they didn't prohibit them from conceiving while the other women were going through their surgery and their postoperative care, and didn't comment on that in their paper. The numbers per group were pretty reasonable, but not huge. And I think the other thing is there's such a huge spectrum of disease with fibroids. Again, if you're dealing with breast fibroadenomas, they don't get to be 7.5 pounds. You know, if you're looking at the range of disease of endometriosis, maybe they have cul-de-sac obliteration and stage 4 disease, but still the difference in terms of grams of tissue between stage 1 disease and stage 4 disease is pretty small. And fibroids, we have this just enormous range that we have to deal with. The final things about this is that they use clinical pregnancy as an endpoint. And again, since we postulate that increased miscarriage rate is part of this picture, that doesn't get us to the true relevant endpoint. And it was unclear how long women were followed for miscarriage afterwards. So again, it was a good study design in many ways, but it probably lacked external validity because it couldn't generalize to the entire population of women with fibroids. So there was a report in 2009 that looked at level B evidence. So if you start to include both randomized clinical trials plus series, you get more studies. Now, the ones that looked at submucous fibroids, still you're dealing with 2 to 4 studies for each clinical endpoint, which again, given the number of submucous fibroids we deal with, is pretty small. But what they found were that submucous fibroids impaired fertility. But that's only part of the story. What's the next part? So if you say submucous fibroids impair infertility, what's your next question? Okay, so if you take them out, does it reverse it? It might. And at least the evidence suggests that for some of the endpoints that it did. And again, when you look at intramural and subserosal fibroids impact fertility, you're getting more studies. You're getting some clinical effects. So again, you see impairment of implantation, ongoing and live birth rate, and increased risk of SAB. But you're not seeing statistically significant differences in clinical pregnancy rate or preterm delivery. But again, studies relatively small numbers. So again, that they were able to look at myomectomy improving outcomes for submucosal fibroids. So comparing to women with fibroids with no surgery, that there was almost a 2-fold increase, or a little bit more than a 2-fold increase in clinical pregnancy rate, which was significant. But they didn't see any improvement in intramural fibroids and fertility. But again, looking at the number of studies, given how many women come into our offices every week with fibroids, the ability to capture that data and really make sound conclusions is really, really frustrating. So at least the thing that probably has the best evidence is that submucosal fibroids do have some fertility impairing effects, and removing them reverses that. Now the question is it really the submucosal fibroid? And it may be, because there is some biologic evidence that submucosal fibroids have different karyotypes, they may express different gene patterns, so there may be something intrinsically different about them. It may be their location, so if you were able to pop a fibroid out of the intramural component and glue it into the endometrium, maybe it would have the same effect. Or it could be that now in the era of hysteroscopic myomectomy, we're just able to eliminate the fibroid with less fertility causing problems than we get through cutting open the uterus and stitching it back up. It was an interesting comment when we were talking to the FDA going through the approval process for the device that uses focused ultrasound to treat fibroids, and one of the physicians said, well, is it possible that, you know, the energy going through the uterus will go through the endometrium and cause some damage? And I said, well, yeah, you know, when you have an anterior fibroid, it's possible. But have you ever seen a myomectomy? And I'm thinking to myself, there are these times when you have this piece of endometrium over here and this piece here, and you're going, how do I stitch it back? Or do I just cut it out and roll the cavity? You know, and yes, it's possible that some energy going through it may be impairing, but many of us, just like with vaginal deliveries, you're kind of going, okay, I know this has to go back together, but it's a 3-dimensional puzzle, and the pieces are not always clear. And I think that that's the part that many people that actually don't do the surgery don't understand. So again, I think we won't even go into it today, but the way you determine the imaging may be an issue. So again, if you did an HSG on this lady, and I don't know whether the lights are good enough that you can see the cavity here, you'd probably say this is an absolutely normal cavity, no problem. It's only when you look with MRI and you see that probably the normal cavity would be coming here. This is a type 2 submucosal fibroid. So your decision about how it's affecting the cavity probably relates to how carefully you're looking at imaging. Done the same thing myself. I've done sonohistograms and I said, oh, those fibroids are really type 2, they're not that intercavitary, and then, but she's having such heavy bleeding, we'll go after them, and I see multiple type 1 fibroids that are 80% intercavitary. So again, the more you inflate the cavity, the more you get a different perception of what's going on. So even though we start to classify, there are some issues in terms of the way we look at these things. So at least based on the evidence, I would probably allow this woman to proceed with fertility treatment. That, again, I think the possibility of efficiently getting this out via a hysteroscopic procedure is probably pretty low. And again, I think it's also the sort of thing where I do talk to women and go through the options with them. But again, we can talk a little bit about the limits of these evidence-based guidelines. And I think the first thing is to look at the fertility impairing effects of many of the treatments we use. So they've just updated the evidence report, but the last published one is in 2007. And there's substantial risks of abdominal myomectomy, transfusion, 3 to 4% hysterectomy hysterectomy conversion is devastating in the woman who's trying to get to fertility, high risk of recurrence. And they don't even talk about adhesions or loss of an ovary, which again are key issues. That again, we say, well, minimally invasive surgery gets rid of a lot of those risks. Well, yeah, a lot, but still, there's a laparotomy conversion rate of 9% and the hysterectomy rate is small, whatever that means. So, but again, if it's you, it's huge. That's one of the key issues, and that's one of the reasons why I think it's important to be looking at the development of new minimally invasive options. I think if you look at any other field, there's been an evolution from open surgery to minimally invasive surgery to medical management. And when I was a medical student, doing transsphenoidal pituitary surgery was the coolest thing. How many people remember that? Okay, all in the back of the room. So, that they basically go through the nose and scrape out the pituitary gland. And then you'd spend the next week of hospitalization, because in those days, even with that kind of surgery, you were in the hospital for about 2 weeks afterwards, looking at the other endocrine dysfunction that you've disrupted. And now it's almost never used, now that we've got good dopamine agonists, and we've got, only if we've got a macroadenoma and visual field changes will you even think about doing surgery. So I think really we have to be more aggressive in moving in that pathway. I think we're still on the verge of the 20th century in terms of fibroid care instead of making it all the way to the 21st century. We've kind of gone from the Halsted model of surgery takes care of everything to saying, well, maybe there's some other things we can do, but I think we really haven't made that transition yet. And at least my hypothesis is that the fertility enhancing benefit of treating the fibroid is counterbalanced by the fertility impairing effect of the treatment. And that's what I always keep in mind. So if there's only one thing that you carry away today, this is what I'd like you to think about. So that less invasive the therapy, potentially the more beneficial the outcome. So how many people here refer women for uterine artery embolization for fibroids? Okay, not too many. So why don't you send anybody for UAE?
Well, nobody in my practice wants to go there, I can tell you that.
Okay.
Cancer thing,
Yep.
not so much.
Yep. But what about if you have a woman with fibroids, black woman, so picture D, where she had 25 small fibroids. If she still wanted fertility, why wouldn't you consider UAE? Because you know the morbidity of doing that surgery is going to be tough.
Our radiologist won't support doing it for future fertility sparing.
Okay, and why do they say that?
They say there's not sufficient evidence to support that it's safe for future pregnancy of the uterus after UAE.
Okay, and how much high quality evidence do we have that myomectomy gives you good quality outcomes for fertility? So, you know, we're in a double bind, but that's exactly, usually it's our residents that come in and say, oh, I can't do that because it's going to put her into menopause, and that's a big issue. So first of all, UAE is very effective for fibroid care. There have been 5 RCTs over 550 women. There's no difference in patient satisfaction at 5 years, no difference in major complications. And the major issue with it, there's an increased risk of surgical intervention within 5 years. Now, if you take the uterus out, then there's no future interventions to that organ that you get. Now, I hypothesize that there may be other downstream surgeries that you get because of removal of your uterus, especially if you remove the ovaries, and that's another area we're working on. And it may also be due to confounders. So, you know, I'd love to know how many of those women had adenomyosis, how many of those women had other, kinds of bleeding disorders. So that I think that if you're looking at symptom control, UAE is a choice. Now, this is the best evidence to say you shouldn't do UAE for women who want future fertility. So again, substantially less than 100 patients, that they randomized women to UAE and myomectomy. They didn't get roughly equal sized groups. This was published in 2008, so it was probably done at the early days of UAE. Were they really worked up adequately? What else was going on that made things different? But they did find in this level A evidence study that women were more likely to get pregnant, more likely to deliver, and less likely to have an SAB if they had a myomectomy versus UAE. So this is the best reason that your radiologist can cite. But when you look at all of the criteria, the Cochrane review, which is the Gupta reference, says there's very low-level evidence suggesting that myomectomy may be associated with better fertility outcomes than UAE. So I think that with appropriate counseling, I believe that you can send women for UAE. Again, I kind of make the distinction that do you want to optimize fertility or do you want to keep that door open? Because again, we found in our research that black women really don't want to give up their uterus. They don't want to give up that fertility option, even though their plan may be never to pursue fertility. So I think that kind of trying to prioritize things and also looking at the uterine anatomy. Again, if you've got a 6 centimeter subserosal fibroid you can take out in a minimally invasive procedure, that's going to be a different outcome than when you have 45 intramural fibroids. And this is a very misinterpreted study. This was published in the Green Journal in 2007. It came from follow-up of ovarian reserve testing within one of those randomized clinical trials in Europe. And the way people interpret it is that ovarian reserve is impaired following UAE. And in fact, the title of the paper pretty much said that. But there's no statistically significant difference in any of these parameters. So there may be a trend, but I don't think that this tells you that there's impairment of UAE compared to hysterectomy. Now, I'd like to have a bigger study to know for sure, and we're doing that as a part of 2 different studies that we're doing. The other thing that's really interesting about this study is that they did do AMH, but they extrapolated what they expected as an age-related decline. So I think whenever you kind of put your own curve in there and say, well, I think this is where it's going to land, that they still didn't find a significant difference. So I think that there is some caution. So I still tell women that myomectomy is the gold standard, but it's gold-plated at best. That I think that if we're looking for solid gold answers, we don't have them for fibroid care. And in fact, one of the earliest examples I had, was telling everybody, well, you may go into menopause following UAE, that we don't know what this, how frequently this occurs. And sure enough, my patient went into a period of amenorrhea, and she said, well, yeah, we talked about this, no big deal. Well, 9 months later, she had a lovely son. And it took her a while to figure out, we didn't talk about weight gain when we talked about amenorrhea following UAE. So, there are thousands of women who have delivered babies successfully following UAE. So again, we take a little kernel of knowledge and we generalize it. And so I think that if we look at, again, looking at broader outcomes and level B evidence, that the adverse effect of UAE on ovarian reserve primarily appears to be in the women that should not be seeking fertility with their own eggs. So I think that there's some reassurance in that. And again, there is some differential guidance. So these are the two European perspectives that the NICE recommendations from the UK said that women should be informed that the effects are uncertain, which is pretty open. It doesn't sound like it prohibits it. And again, one of the French guidelines said it's not a first-line treatment who want to be pregnant, and that they must be informed of risks. With the UAE, our ACOG guidelines are badly out of date. They were published in 2008. They do say, however, that it's a safe and effective option for women who want to retain their uterus. And then the IR guidelines say it's a relative contraindication if you want to maintain childbearing. So there's absolutely no prohibition from any of the US guidelines. Again, and I think I like the way this is worded, especially the women who are not good candidates for myomectomy, because I think, again, none of us want to be doing that myomectomy when there's 37 small fibroids. And so I think that it fits very well. I'm going to speak just for a minute about MR-guided focused ultrasound, which is a technique that uses multiple ultrasound waves to cause thermal ablation, and the guidance is by MRI. Again, this is the trial I alluded to before, where we randomized women to focused ultrasound and myomectomy. 50% term delivery rate. The bad news is that was 1 of 2 enrolled subjects, though, but at least we got a case report out of it, or a small case series, I guess, with 2. So you got to make things work in the academic world. But this is a study I would really like to see done at some point in time. And again, we have followed evidence about good pregnancy outcomes. Again, this is badly outdated, and I've tried to get the data from the company and say you got to publish this. But at least the initial outcomes were good. And I was amazed that 64% of these women were allowed to labor. That I'm not sure if I was dealing with a patient with big fibroids and undergoing an investigational procedure, I would have let her have a vaginal delivery. But somebody's got better coronary arteries than I do. And they had good outcomes with mean birth weights of 3.3 kilograms. So, that again, thank goodness somebody does obstetrics still. So again, the recommendations for MR-guided focused ultrasound are that, again, we got good short-term outcomes, but we need longer studies. The RCT we've run looks at women up to 36 weeks, and our data lock is just about a month away from being complete, so I hope in the next year I'll have some data for you on that. But I think this is one of my favorite lines from the evidence report. report on fibroids. The dearth of high-quality evidence supporting the effectiveness of most interventions for fibroids is remarkable given how common the problem is. I think it's been understudied and emphasized in both. We as clinicians and our patients deserve better evidence. And one of the big projects we're involved in right now is a nationwide registry that's funded by ARC and PCORI, and we're aiming to look for 10,000 women and looking at their long-term outcomes. So I'm hoping that this will be a good option. But I'm going to stop here and leave time open for questions. And I'm pleased everybody stayed awake despite the game last night, so thank you again.
I learned a lot, so that's awesome. I love that. Second of all, I did ask Abby to finish a little early because we have resident interviews. What time is it? I can't read that far. So let's do the question thing, and for those of us who are actually interviewing, we can leave a little early so there can be more questions if that's the case. But I'm thinking that there's a lot of questions here. Alex, you start. What do you got?
Okay. So,
Nice.
because you got me before I raised my hand.
She's psychic.
Yeah. So, I think one of the portions of this that's even more understudied is the interaction of medical and surgical treatments, right? And,
Right.
you know, we always talk for years about all of the studies with respect to myomectomies and prompt retreatment, and it saves you credit, but does it make the surgery harder? Has that been studied at all in the context of things like MR-guided focused ultrasound? And B, what do you do in that context?
Yeah, so no, it's not been studied. That I only, well, ACOG does have a statement on it that says that the risks and the costs of GnRH agonists need to be balanced against the benefits. So if I have somebody who can't keep her crit up or who has a fibroid that I can't deal with surgically, and again, my 7.5-pound fibroid we didn't pre-treat because even if it shrunk, we were going to be doing a big abdominal incision, so we just went for it and didn't end up with a transfusion. So I use it very seldom, but it's interesting because if you talk to anybody outside the US, that question is totally irrelevant. Nobody uses GnRH agonists now that progesterone receptor modulators are approved. So I think that's going to be a very interesting story. So that ulipristal acetate is widely used throughout the world. There are two really nice articles in the New England Journal of Medicine probably about a year and a half, 2 years ago now that look at them compared to GnRH agonists and placebo. And again, the real drawback of those studies is that they were done in Europe, so the women tended to be thin and white and have uteri that were no bigger than 300 cubic centimeters. So they, as I understand it, the FDA is making them do trials in the US to look at our 1,200 cubic centimeter uteri and look at a more diverse population. But from what I understand, the trial data is coming out well. So I think we'll have those available. And they've got some really interesting properties, but that's a whole different talk.
Oh, that's good. That was a good question. Thank you, Alex. Other questions, thoughts? Yeah, Jake.
Well, you mentioned, like, do we refer women for uterine artery embolization? I think part of the reason we don't is because we're not radiologists. And so, like, when I see a patient, even if the thought crosses my mind, it's a procedure that honestly, like, even though I've read about, I've never seen. So when it comes to counseling patients, I don't know how to best answer their questions. But when you work with your interventional radiologist and for a uterine artery embolization in a woman who would like to at least retain fertility, which was like the agent that they use.
Yeah.
Because there's some differences there.
Yeah.
How do you find
So first of all, I'd love to invite you to come to our office, because we take the approach that even though we don't do IR procedures, we're the fibroid specialists. We know, how to weigh the risks and benefits. And so, I don't do hysterectomies anymore. But I know how to counsel women. So we kind of use a core fibroid center model. So, and I think that's been part of the problem of adoption, is that there's been little literature in the GYN literature, but there's a lot of studies in the Journal of Interventional Radiology. So I think that the study suggests that recovery is much quicker following UAE than surgery. And the analogy I use is it's like a cardiac catheterization. There's a small incision where the leg meets the trunk. And so I tell patients, instead of taking a balloon up to the heart and opening up a blood vessel, they take it to the two sides of the uterus and use sand-like pellets to block off the blood supply. And they do use different kinds of embolic agents, and that was a little bit of the learning curve, because both the size and whether they were round or whether they were irregularly shaped made a difference. I again use the analogy of the beavers in the pond, that if you want to block up downstream, you're going to do things differently if you're sending twigs versus if you're sending big logs. So the flow takes the embolic agents deeper into the tree if they're smaller. So they've used different agents, and they've now, they used to embolize to where there was absolutely no blood flow. And so there were some cases where they did get complications and necrosis. But if you read the current literature, they say they embolize to near stasis. So there's still some flow going to the uterus. And I think the literature also speaks to the vascularization of the uterus, which any of us who've done a C-hist, know intuitively. There are so many collaterals to the uterus that you cut off the blood supply to the uterus, and in a couple of hours there's revascularization. And that's kind of the principle, is that the fibroids don't revascularize, but the normal myometrium does. But you should absolutely go and see one. I think that if you see one, it makes a world of difference.
Also, I would add that it's a multidisciplinary, like, center of excellence of fibroids. I made that up, although you got that. You would partner with them moving forward if you really had a multidisciplinary team. Klaus and then Cynthia.
So given all the recent attention to morcellation and the risk of leiomyosarcoma, how do you counsel a 40-year-old African-American female that has symptomatic uterine fibroids, doesn't want to lose her potential for fertility, and you're going to talk to her about UAE?
Okay, so I think first of all, the FDA is wrong. I think that I think their numbers, if you go through those old studies, some of which didn't even do any imaging, is wrong. So there's newer literature that suggests that the risk is age-related. And again, at least if you listen to the hearings, and again, that's a very instructive thing to do. If you have time, you can listen to it on the...
Listening to Trump,
It's milder than that, I think. So, so again, if you're in the age of 40, it's more 1 in 1,000, 1 in 1,500, maybe 1 in 2,000, not 1 in 300 and something. So I think the other thing is that there are some tests that decrease your suspicion. So again, although MRI does not predict sarcomas, it can give you reassurance that this looks like a typical fibroid. So again, if there's a question, I'll do an MRI. And I'll talk to her risks and benefits that, again, there are a small subset of my patients that say, unless they see it under the microscope, I will not be reassured. Cancer runs in my family, and if there's anybody that's going to get it, I'm going to get it. But other people say, risk of 1 in 1,500 versus, going through a hysterectomy or even an extensive myomectomy. I'll take UAE and run that risk. There's also some evidence that UAEs don't treat sarcomas. So again, everything other than focused ultrasound has had at least case reports of undiagnosed sarcomas that didn't respond to therapy. So I think you do have to follow them up and make sure. But again, some of my colleagues are saying, oh, we should just do surgery on everybody so we know convincingly that we don't have a sarcoma. I think it was clearly pointed out at the hearings by one of the gynecologists that said, then you're going to operate on every African American woman in this country, and that's not reasonable. You have to say, yes, you could be missing a cancer, but that's a low risk, and the morbidity more than outweighs that.
Ellen has instructed me that I have to be in my chair in 2 minutes. So over in terms of questions, and Abby,
thank you.
I'll see you later.
Sounds good. Appreciate the invitation.
So on that end, the question that is, has anybody tried using either local delivery of drugs like you do with Bertolak acetate to the context of, say, microparticles with UAE, or delivering any of the multitude of agents that our oncology friends have developed for essentially angiogenesis inhibition?
Yeah.
By, say, the UAE type local release?
Yeah, well, and I think that's a terrific question, and actually my mentor and I have a patent back from the 1990s about using local delivery to treat fibroids, and it makes intuitive sense. I mean, you use it for contraception. You have a Mirena, you have a vaginal ring, you have even vaginal foam, delivers differentially to the uterus. And in infertility, we use vaginal progesterone to get the highest level there. So I think we do have an opportunity for targeted therapies for the uterus. And there's also some interesting literature to potentiate therapy. So like with focused ultrasound, there are thermosensitive nanoparticles. You can even put them in the circulation and then apply the energy to the uterus, and only where the particles meet the energy is there enhanced destruction. So I think that companies have been reluctant to move into the gynecologic market, and particularly something that affects the uterus because of potential liability. And I think that most of them don't understand what a huge market it is if they got something successful, that given the prevalence of fibroids, if they had something new and different, it would be a game changer. Yep.
In the earlier days of uterine artery embolizations, we had some problems with patients developing two issues. One, sepsis.
Yep.
And two, they had a necrotic fibrous attack. They went into labor.
Yep.
And have those problems been addressed and resolved, or are they still issues?
Yeah, I agree. I think that there was a big learning curve on fibroids, and I experienced some of those things as well. So I think the embolizing to near stasis rather than complete stasis, really, I haven't seen any reports of uterine necrosis, and I haven't seen any in practice. I think the second thing is that fibroids can be passed vaginally, and that's good because it completely gets rid of the fibroid, but it can be a really ugly process because it can occur randomly anytime a year later or 6 weeks later. And so I think that in general, if you have a hysteroscopically resectable submucosal fibroid, people are recommending take care of that first, and especially if your problem is heavy menstrual bleeding, that makes sense. And then only if the cavity looks relatively normal, then do you consider embolization. Yep.
So one thing, just so Jake knows, first of all, thank you so much for your talk. It was
My pleasure.
spectacular. It was a lot from you this morning. The IR team over at UW is really comfortable doing these. I use the IR department a lot, and I'll be honest, I've only been using them for patients who do not desire future pregnancy.
Yep.
But the IR team has come to my OR a couple times to watch myomectomies, and that way you understand both sides of things. So they'd be more than happy to have you over there. So the picture that you showed, like the fourth picture you showed at the very beginning of innumerable fibroids, right? I have a couple patients with just that.
Yep.
And being honest, I haven't offered them UAE before because of the risks that I've read with regard to pregnancy afterwards. I was just curious, how would you counsel your patients regarding pregnancy after UAE? What risks do you quote them? Things that I've read are, abnormal placentation, low birth weight, preterm delivery. Just curious.
Yep, but all of those things are also in series of women who have uterine fibroids,
Right.
and that there aren't the good series following myomectomy. So I think, you know, that I say that there are some studies that suggest that certain pregnancy complications may be increased, but we also don't have great data on myomectomy, and you know that there are, you know, literally thousands of case reports and case series of women that have undergone UAE and had successful pregnancies. So, you know, again, I don't find that it's my patient who's in my office seeking fertility that typically goes to UAE. It's the person who's trying to keep their options open, you know, and again, you know, I did have a lady like that who ultimately ended up going to myomectomy because she had been putting off taking care of her fibroids for 10 years, because every time she walked in and say, I want to get pregnant, somebody said, you know, you have to take care of your fibroids. And, you know, it took me even 2 years to get her to realize that we wanted to help her get pregnant, but the success rate wasn't going to be possible. But she had like 100 submucosal fibroids. And so we ended up putting in a stent and then doing 2 hysteroscopic lysis of adhesions afterwards. And, you know, again, myomectomy was maybe the better choice, but none of those are easy choices.
So when you see the innumerable fibroids, that picture, I just have like 2 patients, that exact picture.
Yeah.
Coming to me for infertility. Do you recommend going hysteroscopically and taking all the submucosa that you see? How would you, I don't know where to start. Right now they're going to see REI to see if they're big.
Yeah, I think those are the tough things. So, you know, again, you know, some of them aren't feasible to do hysteroscopically. You know, I think I've successfully taken out 7 submucosal fibroids that were all relatively small, but once you get above that, and you're talking 2 and 3 stages, and you're getting into fluid loss at each point, that's when I think, you know, can't say my UAE is absolutely safe, but I think weighing the risks and the benefits, this potentially can get you there in one stop.
Yeah. Thank you.
Alex.
So yeah, so that's always the hardest problem, obviously. So here's another question, and this has certainly been a big change in practice for me, and I actually to a large extent for you as well, moving from a state of insurance to a state of pure interest. So these days, I again, because of the biases we have alluded to, I'm far more likely to recommend myomectomy before IVF than I used to be. And so where do you start that? So, you know, yeah.
Yeah. Well, I think you start with a discussion, and you start by saying, you know, we don't know. There are risks to fibroids, there are risks to myomectomy, you know, you're paying out of pocket, you know, you know, the cavity is impacted, the cavity is not impacted. I think those are the most difficult positions, but again, I come back to the US bias is that, you know, well, you know, this is free in quotation marks, or, you know, relatively small copay compared to your cost of your IVF cycle, and I find that's how many patients make their decisions, that they'd rather do that than to pay $12,000 for an IVF cycle and then, you know, go to a myomectomy later. So, but it's really terrible that we're making those things in a vacuum. The other phrase I use is we should have had a Framingham fibroid project. You know, if we had started out in the 1950s and said, what causes fibroids, how do they impact things, and started studying back then, we'd be in a totally different place now.
That's your program.
Yep. Yep.
So I agree with Nick. I think we really underutilize UAE, partly because, you know, we don't do them, so it's not as comfortable to counsel people. But the other thing I think is that it seems really inconvenient for patients, and I'd be curious to hear how your center is set up, because for us, usually these patients are coming from internal medicine or family practice, so they've already seen a provider. Mm-hmm. Then they come to us in OBGYN, and we have to review things and counsel them about their options. If they then opt for UAE, they have to have, our interventional radiologists want a CBC with platelets and a normal INR, and then they also want an MRI to review, and then the patient has to wait after their appointment with me to go get an appointment for an MRI, and then wait for that. And then they have to schedule a consult with IR, and IR sees them, counsels them, looks at their imaging, and makes a determination about whether they're a good candidate. And then they have to wait again to schedule the actual procedure.
Yep.
Is there a better way to do this?
Yeah, well, I mean, it sounds like to have Laurel or somebody else from the department sit down with the chair of IR and say, how can we do this? And our IRs want to build that part of their practice. And so, and we've started a process for people who are coming from out of town that we get their records, and one of us takes a quick look at the records and says, she's a candidate for a myomectomy, or she's not a candidate for anything except UAE, and do you want us to book simultaneous appointments? So, we'll take a quick look at the records and say, this is what we think are your options. Do you want to set up multiple appointments? But I've even been in the office, somebody came in, billed as a fertility consult. Turns out she's got fibroids. She wants to keep the options open, and back home they told her, no, your only option is hysterectomy. So that's why she kind of couched it in a fertility framework to get into my office to talk about alternatives to hysterectomy. And I've called the IR people and say, I've got somebody here, is it possible you could add them on? And at least we're, in our practice, the IRs, there's somebody doing embolization every day, and they have a lot of emergency cases, so adding on another person to their schedule is not a big deal. If they can get, David Woodrum to see them in the office and then Andy Stockland to do them next day, it's not that big of an addition to their schedule compared to the bleeding liver or the, hepatocellular carcinoma. So, it's a good patient for them. I think we've also been working away from MRIs. Our radiologists prefer to have an MRI, but if they have an ultrasound and they're, not 53 and there's nothing suspicious about them, they'll proceed on the basis of an ultrasound.
So they can potentially get a same-day consult and the next day embolization.
Yeah.
That would be shocking to me.
Having worked in the Mayo system, that's the way the system is set up. Our system is not set up. It's a common thing where, that's how
yeah.
it's set up.
Well, a lot of the surgical services work that way as well.
It is a machine. We're not set up that way. That would take a huge system reboot, but it's amazing.
Thank you.
Absolutely.
But again, maybe you could get it down to one appointment, or again, if you have any record reviews, that you could give the heads up and say, is it possible to, book a joint appointment, those sort of things. That, and I think again, that's where if you're working together, it makes better sense. That, again, I've worked in other institutions where there's a lot of friction, and the IRs, didn't want to take the postoperative care and would dump them on the gynecologists, and that if you're working together for the patient, it goes much more smoothly.
Yeah, I haven't seen any, that kind of friction between specialties, but there's so much geographic.
Yeah, well, and geography is a huge issue. Yeah.
Yeah, I know how it is at Meriter, so it's really unique.
Yeah, I'm hearing a little bit about it, yeah.
Exactly. So at UW, the IR department works really closely with, I work with them a lot, and so we actually do those joint visits where I'll prep the charts, and if I think a patient's a candidate, I prefer MRI before all my myomectomies anyway, and
yeah.
So, just so I can obviously identify exactly the fibroids located, and so we've done joint appointments with IR the same day or next day when they see me as well, just so they can make their decision regarding myomectomy versus hyst. So it is possible, and I would love to start that multidisciplinary clinic over at UW or wherever we want to make it, and I think we're probably in the process of that, but I'm not quite sure the difficulties you guys are experiencing over there, but at least over at UW, they're very well versed in UAEs.
Actually, my experience at Meriter is different than yours. And I work with a specific IR person. I know their criteria, so when somebody comes in and says, yeah, I'm interested in that, we get the MRI, he actually looks at the MRI and decides based on that whether he's willing to do it or not. And the next thing is, patient comes in to have it done.
Yeah, so, you know, and we have in our computer hot buttons, so we know exactly. So if they're going to UAE, we just do the blood work. If they're under 50, they get this set. If they're over 50, they get that set. And
But you can't use the random MRI people. There's only one person that's really interested in building this practice.
yeah, so I think that's the key thing, is you find people interested. So again, just like, you know, if you have a surgeon that hates fibroids, it's not going to work. You know, that you want to get a group of people who are interested in it.
So thank you so much, Dr.
Good,
Stewart,
thank you.
for giving